to discuss this interesting topic, malignant hyperthermia. Malignant hyperthermia is rare but potentially fatal disorder. We can call it as at a hypermetabolic state, which is caused by dysregulation of calcium channels, which leads to sustained muscle contraction. Indian data as such is not available because we are just have started noticing the cases of malignant hyperthermia. So this is a US-based data. It is more seen in pediatric patients, which is 1 in 15,000, and incidence in adult patients is 1 in 40,000. So what is exactly malignant hyperthermia? It is a pharmacogenetic disorder, which is inherited in autosomal dominant, which is caused by mutation of gene RYR1 and CAG-NA1S, which encode for the intracellular ryanodine receptor, which causes uncontrolled release of calcium from the sarcoplasmic reticulum. The triggering agents are potent volatile anesthetic agents and muscle relaxant, depolarizing muscle relaxant, succinylcholine. 60 to 70% of cases are due to mutation in ryanodine receptor, which is located in the sarcoplasmic reticulum, which is responsible for calcium storage in skeletal muscle cells. So in healthy individuals, RYR1 receptors mediate release of calcium from sarcoplasmic reticulum into muscle cell cytoplasm, causing muscle contraction. But what actually happens in malignant hyperthermia? Due to defective RYR1 receptors, there is exaggerated calcium release and also have higher threshold for deactivation of calcium channel and higher threshold for muscle relaxation. So muscles remain in the contracted state. Coming to pathophysiology of malignant hyperthermia, because of uncontrolled release of intracellular calcium, there is muscle rigidity, which is hypermetabolic state, which leads to accumulation of breakdown products of skeletal muscle, which we call as rhabdomyolysis, which leads to hyperkalemia and myoglobinuria. Also, the enzymes from skeletal muscle cause renal failure, which further aggravates hyperkalemia and acidosis, which leads to fatal cardiac arrhythmias, leading to cardiac failure and cardiac arrest. Also, enzymes from skeletal muscle cause disseminated intravascular coagulation. Because of sustained muscular activity and increased muscle cell metabolism, there is enhanced oxygen consumption and excessive carbon dioxide production and heat production. So malignant hyperthermia crisis is characterized by muscle rigidity, hypercapnia, hypoxemia, acidosis, rhabdomyolysis, hyperkalemia, and hyperthermia. So if we divide clinical signs and symptoms as per the order of onset, in the early phase, there is prolonged masseter characteristically after administering dexamethasone. There is inappropriately raised end-tidal carbon dioxide or tachypnea during spontaneous respiration, inappropriate tachycardia, cardiac arrhythmias, specifically ventricular ectopic beats. In the developing phase, there is a rapid rise in temperature. So absolute, rather than giving importance to absolute temperature, what is important is at what rate the temperature is increasing. So it is almost 0.5 degrees Celsius per 15 minutes. There is progressive respiratory and metabolic acidosis, hyperkalemia, generalized muscular rigidity, and in the late stage, there is myoglobinuria, coagulopathy, grossly raised serum creatinine kinase, and cardiac arrest. This is a very useful clinical grading scale, which has considered 5 processes like muscle rigidity, myonecrosis, respiratory acidosis, temperature increase, and cardiac involvement. So this is an interesting clinical grading scale. So according to this scale, when the score is in between 35 to 49, it is a likely case of malignant hyperthermia. And when the score is more than 50, it is susceptible. The patient is definitely susceptible for the case of malignant hyperthermia. So what is important is managing malignant hyperthermia is we should know which patients are susceptible for malignant hyperthermia. So these are the 4 categories. The patients having history of metabolic or musculoskeletal anesthetic reaction, first degree relatives of malignant hyperthermia patient, the patients in whom there is positive malignant hyperthermia diagnostic biopsy, and the muscular dystrophies or myopathies like central core disorders. So when we actually handle the susceptible patient, how we should go about it? Whenever there is clinical suspicion of malignant hyperthermia, there are 2 types of tests which patient has to undergo. One is DNA screening. It is a blood test. And another is muscle biopsy or in vitro contracture test, which is an invasive test. So importance of DNA screening is When the screening test is positive, patient is definitely malignant hyperthermia susceptible. But what if the DNA screening comes negative? It does not rule out malignant hyperthermia susceptibility. Then the patient has to undergo invasive tests like muscle biopsy and in vitro contracture test. Suppose now muscle biopsy tests come negative, it rules out malignant hyperthermia. So the advantage of DNA screening is it is a non-invasive test and it can be done anytime. While the disadvantage of muscle biopsy test, it is invasive and the result has to be obtained within 6 hours of culture of muscle. So the time restriction is there for muscle biopsy, but there is no time restriction for DNA screening. But at the same time, muscle biopsy has more predictability as compared to DNA screening. So when we are dealing with a malignant hyperthermia patient, these institutional facilities have to be there. We should have Dantrolene. Anesthesia workstation preparation should be done appropriately for malignant hyperthermia patient. Malignant hyperthermia cart has to be ready. The personnel should be trained and the team should be available to stabilize critically ill patient. Coming to Dantrolene. So basically Dantrolene is a hydantoin derivative. It is a specific ryanodine receptor antagonist which inhibits release of calcium and that's why it prevents prolonged contracture of muscles. The dose is 2 to 2.5 milligram per kg to be repeated every 5 to 10 minutes. Cumulative dose can be given up to 10 milligram per kg. Some case reports are there. The Dantrolene is used up to 20 milligram per kg. So when we have to stop administering Dantrolene, when the PaCO2 starts dropping down and it comes to less than 6 kilopascal with normal minute ventilation and there is decrease in body temperature. Therapeutic plasma concentration of Dantrolene is maintained up to 6 hours. As Dantrolene is highly lipophilic and poorly soluble in water, it is therefore advisable to dedicate a staff or a team to dissolve Dantrolene sodium while handling malignant hyperthermia case because it's very difficult for one individual to dissolve Dantrolene sodium and at the same time managing malignant hyperthermia case. Regarding mode of administration, as it is alkaline in nature, it is irritant to veins. So it should be injected through a larger vein or a fast flowing infusion should be available. The solution of Dantrolene sodium has to be clear and devoid of any particles while administering. So we have to consider central venous access once the initial crisis is under control. Dantrolene is metabolized by liver microsomes to an active metabolite excreted via urine and bile. The mannitol is present in the Dantrolene sodium. It causes osmotic diuresis and fluid shifts. That's why it is very necessary to have urinary catheter when we are administering Dantrolene to the malignant hyperthermia patient, and urinary output and fluid balance has to be measured crucially. Dantrolene itself has side effects, so it is very important to know how much Dantrolene we are administering. It can lead to hypokalemia and cardiovascular collapse when given in excessive amount. It can cause skeletal muscle weakness, thrombophlebitis as it is irritant to veins. It can cause tissue necrosis if there is extravasation, and it causes drowsiness, dysphagia, and dyspnea. So when the Dantrolene sodium is administered to the patient, it is advisable to have some help around and the patient is advised not to walk alone in the wards or in the ICU. There are two formulations of Dantrolene sodium. One, as we can see in the picture, is Rhinodex. In this, there is 250 milligram of lyophilized powder, which requires 5 ml of distilled water or saline for reconstitution. The advantage of this formulation is it requires significantly less time for reconstitution than the other preparation. So how this preparation actually prepared and administered, I just want to share one video about it.
One vial of Rhinodex has an M-House recommended loading dose of 2.5 milligrams per kilogram for a patient up to 100 kilograms, and a labeled dose range of 1 to 10 milligrams per kilogram, with a maximum cumulative dose of 10 milligrams per kilogram. Rhinodex is reconstituted quickly and easily by injecting 5 milliliters of sterile water to the 250 milligram vial. Agitate the vial until the medication is mixed thoroughly, which should take no more than 10 seconds. The suspension should be a uniform orange color. Draw the reconstituted suspension into the syringe based on a 2.5 milligrams per kilogram dose, then administer Rhinodex by rapid intravenous push to the patient in crisis. For example, for a 70 kilogram patient, the loading dose would only include 3.5 milliliters of Rhinodex, 175 milligrams of Dantrolene sodium. Ryanodex should be administered by continuous rapid intravenous push. Ryanodex can be administered either by injecting Ryanodex into the tubing of an IV line or through a connector with a luer-lock syringe. One vial of Ryanodex provides enough medication for a 2.5 milligrams per kilogram loading dose in patients up to 100 kilograms. However, additional doses may be necessary to reverse the MH crisis. If you suspect that you are dealing with an MH...
So as we can see, the biggest advantage of Ryanodex is the very little time is required for reconstitution, and we require a lesser dose as compared to the other formulation. So coming to the other formulation, which is the Dantrolene sodium, it contains 20 milligram of Dantrolene, which has to be dissolved in 60 ml of distilled water. So in first preparation, it required only 5 ml of distilled water. Here we need 60 ml. And it comes in the packaging of 12 vials. So now how this is reconstituted, we will see in the next video.
With alcohol. Insert a mini spike into each vial of sterile water and Dantrolene. Remove the blue caps. Attach the luer-lock syringe to the mini spike in the sterile water vial and withdraw 60 cc's of sterile water. You do not need to inject air into the vial. Remove the luer-lock syringe and attach the syringe to the mini spike in the Dantrolene vial. Inject the 60 cc's of preservative-free sterile water, then shake the vial for 20 seconds or until the solution is clear. Withdraw all 60 cc's of Dantrolene, then apply the Dantrolene label to the syringe. Hand off the syringe.
So as we can see in this video, this formulation needs a lot of time for the reconstitution. As it is a lipophilic drug, it takes some time. So it is advisable to have a separate team just to prepare Dantrolene sodium when we are handling the malignant hyperthermia crisis to save our time. So as per the Malignant Hyperthermia Association in the US and European Malignant Hyperthermia guidelines, these are the guidelines which tell you stock 60 vials of Dantrolene. If no further Dantrolene can be obtained within 60 minutes, you stock 48 vials of Dantrolene. If further 12 vials of Dantrolene can always be obtained within 60 minutes, and you stock 36 vials of Dantrolene if further 24 vials of Dantrolene can always be obtained within 30 minutes. These are the guidelines given by United States and European guidelines. So now what are the problems regarding storage of Dantrolene? Its cost is very high. It has short shelf life of about 2 years. There are high chances of wasting the drug if we are not handling the case of malignant hyperthermia. And there are issues regarding borrowing the license and procuring the drug. But we are definitely hopeful that with the teamwork and the good efforts in India, we soon will be getting Dantrolene when and as per the requirement. Coming to the workstation preparation, it is important to know, do we really have time for workstation preparation or not? If we have time for the workstation preparation, remove succinylmethonium vials from the theater to prevent accidental administration. Remove all vaporizers and all volatile anesthetic bottles. So we have to replace the circuit hoses, rebreathing bag, and soda lime with new ones. Then we have to flush the circuit. So connect a new rebreathing bag to the patient eyepiece, and with oxygen or air, flush the system for minimum 35 minutes. By running ventilator on volume control mode. So we have to switch from manual mode to volume control. Setting the tidal volume of 700 ml, I/E ratio 1:2, switch off the PEEP, and fresh gas flow has to be very high, like 10 to 15 liters per minute. After this, with the bag and ventilator on the vent position, remove those hoses, rebreathing bag, and soda lime. Allow the bellows to collapse completely, and then again second time we have to replace the circuits, rebreathing bag, and soda lime. So we are replacing the circuit twice before administering anesthesia. Now suppose we don't have time for all these things. We don't have 35 minutes. We have emergency. So what we will do? remove vaporizers from the anesthesia machine, flush circuit for 90 seconds with oxygen or air at the rate of 10 liters per minute using the ventilator with a 2-liter test lung attached, change full breathing circuit and soda lime while maintaining flushing at the rate of 10 liters per minute, insert activated charcoal filters. So this is the key step when we don't have time. On the inspiratory limb and expiratory limb, on the both limbs, we have to attach activated charcoal filters. Maintain fresh gas flow at 10 liters per minute for 90 minutes from the commencement of the anesthesia. After 90 minutes, it is safe to reduce fresh gas flow to 3 liters per minute. Activated charcoal filters can be used at 3 liters per minute up to 12 hours. And after that, the activated charcoal filters are replaced. So this is a very interesting paper dictating the importance of activated charcoal filter. So it has been written that we found that placement of filters in unprepared saturated circuit was insufficient to safely prepare for malignant hyperthermia case. Following flushing of anesthetic workstation with high flow oxygen for 90 seconds, a circuit and soda lime canister change, and the placement of activated charcoal filter on inspiratory limb, we were able to safely prepare anesthesia workstation in less than 3 minutes. A single filter on inspiratory limb was able to maintain a clean circuit for 12 hours with gas flows dropped from 10 liters per minute to 3 liters per minute after 90 minutes of commencement of anesthesia. So this is the importance of inserting activated charcoal filter on inspiratory and expiratory limb. This is how activated charcoal filters are attached to the circuit. When we are handling the patient of malignant hyperthermia, we can label our anesthesia machine like this to prevent mishap. Coming to malignant hyperthermia card, we have to have malignant hyperthermia card when we are dealing with the malignant hyperthermia patient. So what does that card contain? It contains Dantrolene, obviously, at least 12 vials, sterile water for injection up to 3 liters for reconstitution of Dantrolene, 50 ml syringes and needles, lignocaine, amiodarone to treat arrhythmias, 50% dextrose to treat hyperkalemia, 25% mannitol for renal protection, then diuretics, soda bicarbonate to treat metabolic acidosis, calcium gluconate for the treatment of hyperkalemia, adrenaline to treat hypotension, and normal saline for irrigation and injection. Other things which are kept in the malignant hyperthermia card are crushed ice, ice makers, irrigating Foley's catheter, rectal tube, cooling blankets, central venous access kits, then canisters for carbon dioxide absorption, anesthesia breathing circuits, ventilator bellows, blood collection tubes, then labels to send the blood samples, and lab slips. Coming to anesthesia management of malignant hyperthermia susceptible patient, as far as possible, it should be the first case of the day to prevent saturation of anesthesia circuit with inhalational agent. Patient should be given anxiolysis, particularly in those patients which have history of temperature dysregulation, muscle cramps, and myoglobinuria when they are induced to stress. Obviously, regional anesthesia is preferable because it takes away all the triggering factors. We have to give trigger-free anesthesia or total intravenous anesthesia. If patient is given general anesthesia, we have to have a controlled ventilation with the end-tidal CO2 monitor so that we can diagnose the rising trend of end-tidal carbon dioxide with a high fresh gas flow of up to 10 to 15 liters per minute. And we should be vigilant about signs of malignant hyperthermia. So normally what happens is, if the patient is having tachycardia, there is a rise in the end-tidal carbon dioxide. During surgery, what we think is patient is having lighter plane of anesthesia, and we try to deepen the anesthesia with the help of increasing the concentration of anesthetic agent. And there we land into the trouble. So when now we are facing with this situation, we have to keep in mind there are chances of patient is landing up in malignant hyperthermia. The intraoperative monitoring of heart rate, non-invasive blood pressure, saturation, ECG, end-tidal carbon dioxide, core temperature, and urine output are mandatory. Now, during the surgery, if we observe only masseter muscle spasm rigidity, while ABG and potassium is normal, promote diuresis, we can continue with the surgery if surgery is emergency, obviously under monitored condition. Monitor for rhabdomyolysis, monitor potassium level and creatinine kinase 8 hourly, and after the surgery is over, send malignant hyperthermia muscle biopsy. But at the same time, we are facing with the malignant hyperthermia crisis, having 3 or 4 signs of malignant hyperthermia as we saw prior, with abnormal ABG and abnormal potassium level values. Call for help inform surgeon, remove triggering agents, start IV dantrolene in the dose of 2 to 2.5 milligram per kg titrate to effect, intubate and hyperventilate the patient with 100% oxygen. Active cooling should be started. The bear huggers which we have put on the patient should be used for cooling the patient now. Then we have to start irrigating with the cold fluids. Promote diuresis and target urine output of about 1 to 2 ml per kg per hour, and IV fluids to be given 10 ml per kg over 15 minutes. Then treatment of complications like acidosis, hyperkalemia, dysrhythmias. While handling dysrhythmias, we should keep it in mind that we have to avoid calcium channel blockers as it will aggravate hyperkalemia. Then DIC to be treated with fresh frozen plasma, platelet cryoprecipitate, and if there is compartment syndrome, surgical fasciectomy can be needed. Intraoperative investigation like ABG, serum lactates, electrolytes, serum myoglobin, urine myoglobin, creatinine kinase, coagulation profile has to be monitored. Post-operatively, monitor the patient for complications. Report the malignant hyperthermia case to registry. Soon we will be having malignant hyperthermia registry where we should report the case. Post-recovery, patient should be referred to the Malignant Hyperthermia Diagnostic Center. If it is a pediatric patient, the child should be referred to neurologist to diagnose occult underlying myopathy. Medical alert bracelet should be given to the patient so that further mishap can be prevented, and first-degree relatives of the patient should be screened. So what are the differential diagnoses of malignant hyperthermia? So considering common causes like inadequate depth of anesthesia, anesthesia machine malfunction causing raised end-tidal carbon dioxide hypoxemia, sepsis, thyroid crisis, myotonic dystrophy, or neuroleptic malignant syndrome. So how we will rule out these cases? So when we are considering different entities, suppose we are considering thyroid storm. So definitely it will be secondary to insult in hyperthyroid patient. The onset of symptoms will be within minutes. Patient will present with psychosis, delirium. Hyperthermia is slow to progress and it will then go up to 104 to 106 degree Fahrenheit. The symptoms will be like tremors and the treatment will be beta blocker, antithyroid drugs or iodine. Then other conditions like neuroleptic malignant syndrome should be considered where inciting agents will be neuroleptic agents. Dopamine agonist withdrawal, like suppose the patient is of Parkinson's and we have withdrawn the drug before surgery, patient can have these symptoms. Onset of symptoms are from days to weeks. Mental status of the patient will be catatonic, mute. The characteristic symptom will be there will be mild hyperthermia as compared to the malignant hyperthermia. So the patient's temperature will be less than 102.5 degree Fahrenheit. Patient will present with muscle pipe rigidity and hyporeflexia, and the treatment is bromocriptine and dantrolene. So when we are handling these cases, always remember unexplained, unexpected increase in end-tidal carbon dioxide together with unexplained, unexpected tachycardia, unexplained, unexpected increase in oxygen consumption, masseter muscle spasm rigidity, and especially more generalized muscle rigidity after succinylcholine indicate high risk of malignant hyperthermia susceptibility. So we should keep these points in managing general anesthesia cases. Key to success in the management is high index of suspicion, early recognition, trigger-free anesthesia, earliest and administration of dantrolene sodium, as dantrolene sodium is the only definitive treatment for malignant hyperthermia. These are few guidelines. Key recommendations include the dosing regime of dantrolene is based on actual body weight. Dantrolene should be available wherever volatile anesthetics or succinylcholine are used. 36 vials, that is 720 milligram of dantrolene should be immediately available. Within a further 24 vials, that is 480 milligram vials should be available within 1 hour. What are the challenges we are facing in India? Availability of dantrolene sodium, which we are overcoming now slowly. Then tests like in vitro contracture test and genetic testing facilities are not available everywhere, but we are very hopeful that these facilities will be available soon. And Indian registry is yet to come to report malignant hyperthermia cases. This is a message which came on the WhatsApp by respected Dr. Bala Venkat sir, that how we can procure dantrolene injection. The importer is based out of Trivandrum. There is product called as Agilus, which contains 120 milligram of dantrolene sodium, and one box contains pack of 6, which is manufactured by the company Norgine. So now if we purchase, it will have shelf life up to 2017. Total invoice price for one pack is to 6 lakh rupees, including GST of about 70,000. So each hospital can strive to store at least one vial of 120 milligram, which will be dose of 2 milligram per kg for 60 kg patients. So suppose one hospital decides to store one vial, the cost will be 1 lakh rupees for 2 years. So it is definitely less than the price of anyone's life. So we should definitely strive to get Dantrolene sodium in our own institutes. So this is the case scenario, the simulation-based case scenario of malignant hyperthermia, which will just brief how to deal with the malignant hyperthermia case.
Are we ready for the timeout?
Yeah. Okay, we have patient Martha Smith here for an umbilical hernia repair. She has no known allergies. She received 1 gram Ansef. Fire risk score is a 1. We placed a Foley that is draining clear yellow urine. She's positioned correctly. SCDs are on, and we're warming with a bear hugger. Anything else?
Nope, that sounds good.
Okay.
Okay, incision. Thank you.
The heart rate is going up. It must be stimulating. I'll give some more fentanyl. But it's not getting better. The end tidal CO2 keeps climbing. I can adjust the vent settings. What about the temperature? What is it doing? Oh no, it's climbing as well. Let me turn that bear hugger off. Hi, I'm over at OR7 today. Do you think you could stop by as soon as possible? I think I may need some help. Thanks. Bye. Hey everyone, I think the patient is developing malignant hyperthermia. Do you think you could call for the MH kit stat, please?
Yes.
And then can you start working on closing as soon as possible?
Absolutely.
Thank you.
Hi, can I get the MH kit and some ice to OR7 stat, please? Thank you.
Have the MH kit here? Oh, great. Thank you. There's some ice too. I'm going to leave it on the back table and I'm going to put some on the patient. All right? The MH kit's here.
So let's start mixing up the dantrolene at a dose of 2.5 milligrams per kilogram, please.
Okay, that looks to be about 150 milligrams and 7.5 vials.
Okay, let's mix each vial with 60 cc's of sterile water, please.
Okay, will do.
Thank you.
I got here as soon as possible. What's going on?
I think this patient is developing malignant hyperthermia. As you can see, our heart rate, the end tidal CO2, and the temperature are all on the rise. Okay. So I disconnected the patient from the ventilator, and I'm ventilating with 100% FiO2 with my Ambu bag. I've turned off my anesthetic gas, and we've started cooling the patient. Okay. I think next we should work on drawing some labs on this patient.
All right, I'll get working on putting in an arterial line, and I'll draw blood glucose levels, electrolytes, and ABGs every 15 minutes until the syndrome subsides.
Okay.
First vial's going in.
Thank you. We'll also treat hyperkalemia with hyperventilation as I'm doing now. We can give some IV insulin. We'll give 10 units. And then along with that, we'll give 1 amp of 50% dextrose. We can treat acidosis with sodium bicarbonate. We can give 1 to 2 milliequivalents per kilogram of sodium bicarbonate.
Yeah, that just sounds about right. If the hyperkalemia is also life-threatening, we can consider giving 10 milligrams per kilo of calcium chloride as well.
That sounds
Second
good.
vial's going in.
Thank you.
Yeah, the patient's urine's pretty dark. I think this might be myoglobinuria.
Okay. I'll open up our IV fluids to maintain our urine output at 2 milliliters per kilogram per hour. And then we can also give some IV Lasix or mannitol to maintain that urine output. And then lastly, we'll just want to make sure that we call the
So this is in brief how we are going to deal with the malignant hyperthermia case with the good teamwork and the separate personnel or separate team to reconstitute dantrolene sodium and immediate availability of dantrolene sodium. So as we can divide the treatment as the causative treatment and symptomatic treatment. In the causative treatment, important is stop triggering agent, increase respiratory minute volume, give 100% oxygen with high fresh gas flow, continue anesthesia with non-triggering drugs, and repeat dantrolene application until clinically stable. And the symptomatic treatment as cooling of the patient, then stabilize hemodynamics, apply internal and external cooling, treat metabolic acidosis, and perform forced diuresis. So let's be prepared and not surprised now if we get a malignant hyperthermia case. Thank you so much for patient listening.